Hi everyone, today I'm going to be presenting on my client intervention, which I've had chosen solution-focused brief therapy and the emergency department setting at a hospital. So I am currently at Palomar Medical Center. It's a hospital in San Diego in North County. My role there right now is to meet with the patients that may come in needing some mental health help or have concerns, as well as they might be coming in on a 5150 psychiatric hold for danger to self, danger to others, or just grave disability. My role is to meet with these patients alongside the psychiatrist, who is the one doing the assessments and determining where they are going next, as well as their disposition. Once the psychiatrist does meet with the patient, then it is my role to support in that disposition, as well as support the patient or advocate for any of their needs that they might have while they're in the ER. So the patient that I had chosen for this particular intervention, we'll call EP. EP is a 22-year-old Hispanic male. His pronouns are he, him, his. He was brought in by San Diego Police Department on a 5150 hold for danger to self. This happened after mom called 911 because EP was making suicidal threats, stating that he was going to cut his throat and wrist after having an argument with mom and locking himself in the bathroom. He did cut his wrist superficially, but did not need any other medical needs for that. He also came in with the blood alcohol level of 0.183. And he has a previous history of hospitalization, both in inpatient and in the ER. He was last seen approximately 1 month before this particular instance. He has revealed to us that he has a history of sexual abuse. He used to live in El Salvador, where he was born, with his grandmother, and there he was sexually abused by family members and other people. When he got a bit older, he was able to move here to the US with his parents, where he met for the first time his siblings, and it was really hard for him to adjust to a new country, a new culture, and just had a lot of how he would describe some kind of behavioral issues. Along with that, he did disclose to us that he was part of the LGBTQ plus community and was currently struggling with his sexual orientation, which has brought on a lot of these symptoms of depression and just has made his life right now really stressful. He feels uncomfortable disclosing this to his family and just being his true self. Just feels like he is going to embarrass his family or bring shame to them. So it has caused a lot of stress. While in the emergency room, he was diagnosed with major depressive disorder. So the intervention that I thought would be best to use with this patient is solution-focused therapy. It was developed by Steve and Inso, and it comes from the theoretical perspective of social constructionism, which assumes that people learn through interactions with others and have the free will to make their own realities. The key concepts of solution-focused therapy is that we're going to be focusing on the patient's strength, not their problems. It's focused on the present and also not the past. We want to find solutions while also remaining as positive and just focusing on those client strengths. Core techniques that you are going to see in solution-focused therapy is scaling questions, exception questions, and miracle questions. And then you'll also see a lot of core techniques around praising and affirmation and really validating the patient and where they're at. The rationale behind using this therapy or this intervention is just that in the hospital setting and specifically the ER, our interactions are going to be brief. So if you want something to be effective and want something to be therapeutic, then it needs to be brief and there's research that suggests that even one session can be extremely beneficial to the patient. It's strength-based, so in the short amount of time that we do meet with patients, we want to make sure that we are emphasizing and highlighting the strengths so that they are motivated, we are increasing their hope, and we're helping them create goals for once they do leave the emergency room. And the last thing is just that it's adaptable. There's research showing that it is easily adaptable in different settings, such as schools, inpatient, outpatient, and even hospitals. So my evaluation of implementing this intervention with EP was, unfortunately, I was not able to implement it. This is just due to the limitations of my placement. The psychiatrists are the ones completing the assessment. And then during the assessment, that is where it's going to be most beneficial to use solution-focused therapy techniques to really increase that hope, safety plan, create goals for once they are discharging. So unfortunately, I wasn't able to use this, but if I would have used it, I would have hoped to have seen some of the increased hope, that being able to identify his strengths, his support systems, to better safety plan. We would, hope that we would not see this patient again, because we would decrease the readmission rate, and we would have better dispositioned him and providing, the next care and next plan for him, and potentially would have motivated him for treatment even outside of the hospital and outside of inpatient. And at the end, the plan was for him to go to inpatient and receive some more treatment due to how serious his suicidal ideation was, and his attempts as well. And so my overall reflection on this experience and intervention is that ultimately, I think brief interactions can be extremely beneficial and meaningful to the patients, especially if we are changing just the way we interact with them and the things we emphasize and say, really focusing on their strengths, highlighting those strengths can be extremely beneficial without, a lot of effort. And I really do think that all practitioners should be using FT skills and techniques, not necessarily saying that's the only intervention they should be using, but those core techniques can be extremely helpful, especially in, areas where we have to get through patients quickly and we may not have enough time to really engage with them. And because it's so adaptable to various settings, I think it's very effective. And moving forward, I really hope that I can use solution-focused therapy techniques with all my clients in any interaction that I have with them, since I won't be able to do assessments. But I am hopeful that in the future, I can present this to the psychiatrists and hopefully get them on board to using it as well. These are my references, and thank you.